आर्टिकल। उसके बाद तो टीसीआई पे बहुत आर्टिकल आ गए, 3 4 आईजे में भी आ गए, इन्फोग्राफिक्स इंटिव आ गए, फिर वो अपना एक टीसीआई पे भी आ गए, युवा मैथर्स में भी, ये सब जगह चलता रहता है। बट आई थिंक दिस इज द हॉट टॉपिक इन ऑल ओवर इंडिया। पीपल
Yes.
start with TCI and TUA also. No doubt people are doing that job, but still I want to educate everyone okay, what
हॅलो
is the myths. Okay, Ganesh.
हॅलो
Yes,
हां सर,
that's a good
यूट्यूब
initiative.
लिंक ऍक्टिव्ह झाली मॅडम.
ऍक्टिव्ह केलीये का? पण अजून पार्टिसिपंट जास्ती नाही झाले ना? मी शेअर करू का?
नो
म्हणजे
प्रॉब्लेम.
आपण 7:30ची वेळ दिली ना त्यांना.
हो हो. नाही नाही, युट्यूब लिंक पण तयार केली गणेशने. मग ते
ऍक्टिव्ह
कसं मोर
झाली
दॅन.
मॅडम,
हा.
ऍक्टिव्ह झाली, करू शकता तिथे पण जॉईन.
ओके.
हो.
ठीक आहे.
चालू करायचं ना?
11 पार्टिसिपेंट्स आहेत.
I think so the people are आएंगे.
सर 5 मिनिट्स कॅन वी वेट?
Yeah, definitely.
5
हा.
मिनिटांनी आपण करूया. हा.
5 मिनिटांनी लगेच करूया. मी कॉन्टॅक्ट केलाय दोघा तिघांना, होत आहे ते जॉईनच होत आहे.
झालं सर? मावशी झालं.
गणेश सगळ्यांना म्हणजे म्यूट ठेवा. आम्ही सगळे होस्ट को होस्ट करू सोडून.
येस येस.
म्हणजे स्पीकर्स आणि मॉडरेटर्स आणि आम्ही दोघी तिघे. बाकी सगळ्यांना म्यूट ठेवा.
हा, बरोबर आहे.
वैशाली मॅम 5 मिनिटात जॉईन होत आहे. सेकंड मॉडरेटर ट्रॅव्हल करताय त्या. विनायक पाटील सर होतील आता.
मनीषा पण नाही आहे झालेली, मनीषाला पण सांगायला पाहिजे.
मॅडमचा फोन आला होता, त्यामुळे मी 10 मिनिटात होत्या, केसमध्ये होत्या. येते.
बरं बरं.
तर तुमच्या ओझोन ग्रुपमध्ये नैना पण आहे, नैना जोशी.
नैना जोशी आहे ना मॅडम?
हा, ती माझी कलिग आहे सर. आम्ही म्हणजे जेजेला सोबत होतो. मी एमडी करत
अच्छा
होते आणि ती
अच्छा.
डीए.
हो. अच्छा. सांगतो मी तिला.
हो, तिला पण मी रिमाइंडर दिले की आज जॉईन हो म्हणून.
अच्छा.
So this group is mainly म्हणजे for geriatric patients साठी असं आहे का सर?
नाही नाही, anesthesia group मॅडम.
ओके.
We provide anesthesia services to many corporate hospital at Aurangabad.
ओके.
Right now we have 35 people
ओके.
in our group.
अच्छा.
सॉर्ट ऑफ ग्रुप ना सर, ग्रुप
Huh?
ग्रुप प्रॅक्टिस. सॉर्ट
Yes,
ऑफ
group.
ग्रुप प्रॅक्टिस ना.
It's a group practice only.
And it's mainly cardiac?
Everything, cardiac, neuro,
Cardiac.
general
Okay.
anesthesia.
ओके.
मला वाटतं चालू करूयात आपण अदरवाईज.
हा 5 मिनिटं तर झाले सर.
चालेल.
काय म्हणतात रुपाली, करूया?
हा,
हो,
आपलं
हो.
चालू करेपर्यंत अजून
चालू
जाईल
करूया
ना
मॅम.
तुम्ही.
सुरुवात करते
ओके.
मी.
हा.
1 सेकंड. मॅम चालू करते मग.
हो कर.
Good evening to all. On the behalf of IC MIRAJ-SANGLI branch, I, Dr. Rupali Gorgide, Secretary of Branch Secretary, welcome you all. Today we have with us renowned speakers from Gujarat and Aurangabad. One is Dr. Tushar Choksi sir, who is also known as Infographics man. Welcome sir. And Dr. Balaji Asegaonkar, who is our SAM's president. Welcome sir. And today we have two dynamic moderators from Mumbai. Dr. Vaishali Mohor ma'am, who is my PG guide during my residency, and Dr. Dipti Haridas. I also welcome all my senior colleagues, my senior teachers, and SAM's office bearers and IC MIRAJ-SANGLI branch bearers. Now I request our branch president, Dr. Vasudha ma'am, to brief about today's webinar. Over to you, ma'am.
Thank you, Rupali. Good evening, everyone. I, Dr. Vasudha Jadhav, being a president of IC MIRAJ-SANGLI branch, welcome you all for today's online CME on behalf of IC MIRAJ-SANGLI branch. I welcome Dr. Balaji Asegaonkar, Dr. Choksi, Dr. Vaishali Mahur, Dr. Dipti Haridas for giving you a valuable time for our branch. Both topics are important from our day-to-day practice point of view. First of all, if we take anesthesia in cath labs, every time, everywhere, cardiac anesthetist cannot be available. So anesthesiologists who are not trained may have to give anesthesia, especially for cath labs. Procedures like coronary and peripheral angiography, angioplasty in the form of monitored anesthesia care. And also for procedures like device closure and many more procedures which may require GA. So anesthesia plays a vital role in case of CCL procedures. And there are patients with multiple comorbidities, so anesthetist has to provide complete integrated anesthetic care outside OT with available resources. So it is quite challenging. And I think from today's lecture, we will gain knowledge how to face these challenges. Now, if we take a second topic, that is TIVA. use of intravenous agents for induction and maintenance of anesthesia using manually controlled infusion rates to maintain a stable hemodynamic abyss index between 40 and 60. So actually, I think it is considered a GA in office-based setting. Dr. Tushar Choksi, who is a well-known personality, he has written a very good article on it, a very informative article, that is re-emergence of TIVA during COVID times. So he will throw light on this topic and he will enlighten us with his knowledge. So over to Dr. Manisha Patil for further proceedings. I will not waste much time. So Dr. Manisha Patil, has she joined?
No, ma'am. First, Dr. Ruta will introduce. First lecture is Dr. Tushar Choksi, sir. So I request Ruta to introduce today's moderator for the TIVA TCA lecture. Ruta? Ruta?
Ruta has joined?
Yes, sir.
She-
Hello,
Yes.
everyone. Am I audible?
Yes, yes.
Yes, you are audible.
Okay. Thank you, Rupali. A very good evening to all the respected faculties, my seniors, and my friends. It gives me great pleasure to introduce you our moderator, Dr. Dipti Haridas, madam. She is very renowned consultant anesthetist from Fortis Hospital, Mumbai. She is very well experienced, working for more than a decade in the field of anesthesiology. She has completed a fellowship in neuroanesthesia and critical care from Kokilaben Hospital and Research Center, Mumbai. And that is the area of her special interest. She has special connection to MIRAJ also, as she has completed her MBBS from GMC MIRAJ. Welcome, Dr. Dipti Haridas. Over to Dr. Rupali.
Thank
Now
you.
I request Dr. Vinayak Patil sir to introduce our today's first speaker, Dr. Tushar Choksi sir. Vinayak Patil sir. Sir, can you hear me?
Vinayak has joined, I think, but he's not seen.
Any one of you can introduce him.
Yes,
Rupali
that's what
madam or
Rupali, तू introduce करतेस काय?
he has already displayed his introduction
Because
slide.
he was there just a few minutes before, but I'm not able to see him just now.
No, you can introduce madam, Dr. Tushar.
I
He
just
has
talked
already
with him.
displayed his slide.
Yeah. I just talked with the Vinayak sir. Some network issues there. I will introduce.
Okay, you
Good
introduce.
evening. Yeah. Dr. Tushar Choksi sir doesn't need any introduction, but as a part of the webinar, sir is currently working as a consultant private practice in Vadodara Medical College, Gujarat. He is a freelancer practice consultant. His area of interest is he has a 32 years of experience in TIVA, NORA, Euro anesthesia, laparoscopic anesthesia, ENT anesthesia, pediatric anesthesia. He is also pain specialist. He is a visiting faculty at Parul and Savitha Medical College, also at Eurocare Hospital, Dhavni ENT Hospital, Sterling Hospital, and Arpan Surgical Hospital. There are so many rewards in his crown. He is a founder of Tivani OFA Foundation, Facebook group of in India. He is an international, national, and state local level speaker. Also, he started smartphone and tele anesthesia practice in India. He started first time infographics in anesthesia. That's why he is also known as an infographic man. So over to you, Tushar sir. Welcome you, sir.
Thank you, Dr. Rupali, and very good evening to all the SEMS office bearer and Sangli branch ISA. I'm starting, I'm not wasting any time. I'm starting my presentation. Can you see my slide?
Yes, sir.
Yes,
Hi.
sir.
Okay, I'm moving to second slide. Can you see my second slide?
Yes, yes.
Okay, fine. Now, today's my topic is, see, before I start this lecture, actually I was giving lecture on TIVA, total intravenous anesthesia. Now, since last 3 years, I have added the word TCI TIVA because since 15 years I was doing TIVA practice, but since last 3 years I have shifted myself to TCI. So I am going to talk about both the way TCI and TIVA and completely knowledge about A to Z, what you want to know and what is my experience and what practically you will see at the end of this lecture and what are the updates and what we have found in all over India. This is the fourth society in the world, that is the Association of TCI TIVA Anesthesiologists, and I'll request everyone to become a member of this society. So my poll is that how many of you are giving TIVA or TCI TIVA? Like TIVA, everybody is giving TIVA, but who is giving TCI TIVA? What is your definition of TIVA and TCI? What is your experience of TIVA? And basically, if going further than TCI, will you give TIVA and TCI in your practice? If you have not started, then please consider after this lecture what will be the advantages of starting TIVA practice. My lecture roadmap will be, I'll start with the basic part. My lecture will be very practical. I'm not going to talk about the textbooks. I'm not going to talk about the journal references, everything, whatever that I have learned from my 32 years of experience and what you want to know, that I will going to tell you. First is history, definition, types of TIVA, indication, advantage, disadvantage, TIVA drugs, TIVA combination, methods of giving TIVA, TCI, syringe infusion pump, target control infusion, my own infusion, closed loop system, TIVA in different groups of patients, surgical procedures which we are doing under TIVA, checklist, monitoring, updates and TIVA apps. Now, what is the future of TIVA? And at the end of this, what will be the take-home message? What will you gain in this lecture? And what is your opinion? And it will be open for the question answer. So if you go to the history of TIVA, then TIVA is almost 350 years before. It is even older than the what invention of the anesthesia done 175 years before. First, it was started in Oxford, then in 1665, 1872, 1905, 1921. Then in 1936, when sodium thiopental was invented, then it has changed the inhalation practice and it started with the TIVA practice. And after that, ketamine came in 1962, propofol 77, remifentanil came in 1996, which introduced just now in the Indian market. So we are almost 30 years behind. Dexmedetomidine 1999, ramimezolam 2020 May, swamifol is now going to be invented in, means already invented, but it is in third phase of trial, that is in 2023 it will come. So timeline from 1932 to 2020, we have a TIVA, almost every 20 years we are changing the scenario of TIVA TCI practice. Now I'm going to break the myths and misconceptions about the TIVA and TCI. What is the definition of TIVA? People still don't understand what is TIVA. So it's a simple definition. It is a technique of general anesthesia, which uses combination of the drugs given exclusively by the intravenous route. As its name suggests, total intravenous anesthesia without the use of inhalation agent like gas anesthesia, including nitrous oxide, but oxygen, compressed air or helium are the exception. Now, second myth is coming as, sir, TIVA is given at the time of maintenance only. No, it is not like that. TIVA can be used as an induction as well as maintenance. So those two things you can remember. Now, TIVA is becoming popular because since last 4 years at the era of the corona, we have used, and my article is very popular now because gas gives rise always side effect. I'm not telling that gas is not, TIVA is not giving side effect, but gas is more, I think, disadvantageous than the TIVA anesthesia. Now, second misconception, what are the types of TIVA? So I have simplified with endotracheal tube, without endotracheal tube, with supraglottic airway, without supraglottic airway, with nasal airway, with oral airway. And if you are not using any airway devices, then also it is called a TIVA. Simple for a 5-minute surgery, 5 minutes anesthesia to 50 minutes anesthesia without any airway. And if you are using TIVA And in these, all the drugs which are given IV, whether it is a muscle relaxant or any pre-medication, it is come under the TIVA drugs list. Now, TIVA indication, practically in each and every surgery, remember my word, each and every surgery, every system, whatever the specialty is there, we can give TIVA and TCI TIVA. So these are the listed indication almost in all surgical procedure. Airway procedure are the main advantage of that. Patient is having a post-operative nausea risk, daycare surgery. It is coming in a very common way now. Short procedure, madam told in the beginning of this lecture, it's a NORA situation. Trainee teaching, anesthesia in non-operative locations where inhalation agents and trolleys are not available. Patient choice, neuroanesthesia and neuromonitoring. These are the branch. Neuroanesthesia is coming. It's a tremendously in the all over the world. In remote location means if you are in the cruise or if you are in the battle of the field where inhalation agents are not available, trolleys are not available, and you have to do some of the major surgery or minor surgery, you can use the TIVA. Malignant hyperthermia patient susceptible, and if you are expecting that anticipation of intubation or extubation. Advantage, except for a slight prick in the arm, the patient is unaware. The prima facie requirement of starting TIVA is you have to take the vein. No mask over the face, that is the biggest advantage. No sudden concentration of the gas vapor, no risk of malignant hyperthermia, very low incidence of postoperative delirium. There are hundreds of articles proving that part. Less chances of emergence phenomena. And when I started my practice with the ether, then trilene, and then halothane, at the end of the day, I was flooded with all the inhalation agent in my body. And you don't believe that I was little bit tired at the evening time. So there is no smell of the volatile agent. At the round, a patient is usually most grateful. And you are also having a very good advantage of that. Better preservation of the cerebral autoregulation, reduce stress response. Patient wake up like it's a natural sleep. And after coming to TCI, target control infusion, it is like a boom. Even my golden statement for anesthesiologists in all over the world is to kill the patient under anesthesia is now becoming a dream. Consider that golden statement. Less post-operative nausea vomiting. Now there are good drugs are coming in the market like amisulpride. So TIVA agents are very good now. Less operating room pollution. You don't require a scavenging system. In war situation, ambulance transport, unexpected.
मला काय माहिती आली असते
TIVA is given to each and every system, and all the systems are favorable listed here. Central nervous system, immune system, cardiovascular, post-operative pain, older patient, geriatric patient, oncology, renal system. And you won't believe then in India, some of the cardiac anesthetic started with the supraglottic airway with total target control infusion, PCI TIVA in bypass surgery and another cardiac surgery. So that is a very good news for me also. And people have completed 1,000 cases in Mumbai. But coin has two sides. So there are some disadvantages. Pain on the injection, because I have told you that the prima facie requirement is to take the vein. Injection is irreversible, disposable. Sometimes it is costly, but since last 3 years, I am following the price list. Now it is becoming the pump which was available at 2.5 lakhs rupees of TCI, now it is available at 1.5 lakhs to 2 lakhs rupees. Incidence of awareness, if not given properly, if you have not trained yourself, if you are not aware of the pharmacology of the TCI TIVA drug, then it is likely that your patient may be aware. So better you have to use a BIS monitor or any anesthesia depth monitor. Undetected error in the delivery device. All the infusion pump, you should be master, and you should always before starting your target control infusion, you must attend some of the webinar or some of the workshops and send, or if you able to go to the YouTube, then there are so many videos are available how to set up the pump. Not having any another apparatus to carry TIVA, possibility of not finding, if you're not able to find the vein, then you are nowhere. You have to start with the inhalation agent, shallow respiration, risk of bacterial contamination, caution in prolonged procedure or obese patient. Now, this is not, I think, disadvantage, because I had started giving 7 hours, 8 hours of TCI TIVA in my patient. Difficulty in knowing the blood concentration sometimes. Now, people are telling what will be the advantage of TIVA and what the TIVA gives for anesthesia. We have learned that TIVA gives hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, and neuromuscular blockade. All these drugs will complete the anesthesia circle in our TCI TIVA armamentarium. Which are the drugs we are using? Now, whatever the drugs in your theaters are there, majority of that are benzodiazepine, narcotics, propofol, ketamine means anesthesia induction agent, dexmedetomidine, muscle relaxant, adjuvant drugs. They are easily available in almost all operation theater. And if you are working with the endoscopy unit, cardiac unit, or radiological unit, then outside OT is also available. All these drugs can be given to any subset of the population from pediatric to geriatric in easily titrable doses. This is my very good slide where you will find all the drugs which were invented in last 175 or 78 years. We have invented more than 65 drugs. Still 45 drugs are in use, and we have liberty of using TIVA drugs more than 25. So this is very good slide. So what is the ideal TIVA drug? People are asking, sir, which is the ideal TIVA drug or which is the anesthesia ideal drug? So these are the characteristics: rapid onset of action, rapid and predictable recovery, potent and lipid soluble. Not lipid soluble, it should be water soluble also. Stable in any solution, whether you put these drugs in any pints or any, it can be combined with any chemically compatible with any other drugs. Most important, so I have done combo of the drugs. I have done all the drug mixings, and then we have found a very good article which will be showing with the next successive slides. No perivascular sloughing if extravasated. Be careful, at least for etomidate and propofol. Not absorbed by the plastic, does not promote bacterial growth, devoid of adverse side effect, and low cost. So from all these ideal TIVA drugs, according to me, two drugs are coming in the pipeline, that is propofol and dexmedetomidine. And still further than that, ramimezolam and not remifentanil, ramimezolam and ciprofol is coming the most ideal drug category in the 95 to 100% of the characteristics. So these are the TIVA drugs toolbox. These are the drugs lying in each and every theater. These are the listed. You know all these drugs. Now, which are the ideal anesthetics or which are the IV anesthetic drugs? I will go one by one with my infographics within one minute, and I will show you one of the major headings of that part of the drug. Now, propofol. Propofol is the main prime drug in all TIVA and TCI practice and in all combination. Initially, it is given in the dose of, I think everybody knows that, but still I am repeating, 2 to 2.5 milligram per kilogram if used alone. But if you are going for TIVA mixtures without TCI pump, then it should be given in 1 milligram per kilogram intravenous or in infusion. Suppose you have maintenance that 6 milligram per kilogram per hour, that is for the 70 kg ASA1 patient. And co-administration of the propofol and remifentanil by target control infusion is highly effective, and it is the ruler of the all over the world in TCI TIVA practice. On right side, we have a TIVA doses and TCI doses with different stages of anesthesia. And this is propofol. This is propofol infographics. And what I want to tell you that you can see what basically this way you have to see. Propofol is compatible with all the drugs, ketamine, midazolam, dexmedetomidine, fentanyl, lidocaine, and compatible with the other fluids also, right? So that is the way propofol is used. Now ketamine. Ketamine is my most popular drug. According to me, one survey is done all over the world, which is the most, I'm not telling which is the most commonly used or which is the most ideal drug, but most popular drug for the anesthesiologists across the globe since last 50 years. People came out with the 45% of the anesthesiologists came out with the ketamine. And ketamine, I called it is a Brahmastra. Key role and main drug in TIVA, best analgesic, amnesic, and opioid sparing effect. All the properties of the anesthesia is there. Dose is less than 0.5 milligram per kilogram if you are using alone or if you are giving in combination with the propofol. It is anti-hyperalgesic and anti-tolerance effect. Anti-hyperalgesic means hyperalgesia is what? If you are withdrawing narcotics from the patient post-operatively and suddenly patient gets a higher pain, means more pain. So it is called hyperalgesia, and that hyperalgesia only and only can be relieved by the ketamine. This is ketamine in TIVA, only intravenous anesthetic. The beauty of the part of the ketamine is that what I want to highlight, that ketamine is the only drug in all the drugs invented in the pharmacopoeia till since last 500 years. Ketamine is the only drug which is given by all the routes, whether you give oral, whether you give intratracheal, IM, subcu, rectal, oral, and nasal, whatever the way you can give and that is beauty of the intravenous. This is ketamine. It can be mixed with the all type of anesthetic and narcotic. Like all people are here sitting in the webinar, they have used with the midazolam, propofol, then dexmedetomidine. So one of the established drugs. This is ketamine infographics. Third drug is dexmedetomidine. Dexmedetomidine came in the Indian market since last 12 years, and it is the best drug available in the India, and it is 7 to 10 times more potent than clonidine, most ideal anesthetic drugs available. And I will request everyone to use this agent because it is a very good agent. But before using this agent, you must go with the pharmacology of this. And the pediatric TIVA, Dexcate or Ketodex combination, both the terms are, some people are telling Dexcate or some people are telling Ketodex. So it is used in the pediatric TIVA or opioid-free anesthesia. Here, all the type of the anesthesia stages you can get: sedation, then conscious sedation, hypnosis, analgesia, anesthesia, deep sedation, whatever you can, that you can take from the dexmedetomidine. Dose ranges from 0.5 to 1 microgram, and maintenance infusion is 0.6 microgram per kilogram per hour. So this is dexmedetomidine infographics. 10 years back, people were telling me that I'm not using dexmedetomidine. So I have, from dexmedetomidine mouth, I have prepared one prayer. Those who are not using, for them. Hey buddies, I am dexmedetomidine. My pet name is Dex. I am your complete friend to play with you in all games: IV, IM, oral, spinal, or nasal. But my favorite game is intravenous with all the stages: sedation, hypnosis, analgesia, anesthesia. I love to play with the small babies to old age players. So you can give 1 day old child to even 100-year-old age patient. But during playing with me, be careful. I am very delicate and fall down with the weak player. So the main, I'm not telling disadvantage, but the main effect is it causes bradycardia and hypotension. So be careful. I can also play in the industrial, so can be given in the ICU patient for continuously for 48 hours. I'm always available to play with you and allowed me to play with the others. Let us play and enjoy with me. Don't neglect me, though I am new player. Still people are, and believe me, in England, this dexmedetomidine is not available. And if it is available, it is under the lock and key, and they have to ask from the NHS. Then it is available. Here the thing is reverse. We have to ask about the remifentanil now. So this is the difference between Europe and India. Her drugs induction is etomidate, excellent cardiostable drug, but I am not using frequently, hardly 1 or 2 bulb in the month. It can be used in the cardioselective patient. This is infographics. Opioids. There are 2 opioids. Fentanyl is now not using by so many anesthetists. Remifentanil. Remifentanil is nowadays very hot cake for the anesthesiologists, and we have come out with the remifentanil guide from the IOTA. It is available in India 1 milligram, 2 milligram. Initial dose is 1 microgram per kilogram. TIVA maintenance is 2.25 to 5, and post-op period you can continue with this. See, this is the only drug available in the market for the anesthesia which can be given only by infusion. Believe me, since last 2 months, I have got a complaint from the anesthesiologist, sir, my patient, 1 patient expired and 2 patients became arrested. So don't give IV straight, this agent. Fentanyl infographics, remifentanil infographics. Then ramimezolam. Ramimezolam is not available in India. I hope so. It should be available by 5 years, but it is available every part of the world, and it was invented by Japan. It is called as a Payon, then Payon company, and it is available in Japan, US, China, and all European countries. It's a combination of narcotics and benzodiazepine. So switch on, switch off anesthesia. It's a very good agent, and my friends in Japan, they are telling me that we are very, very happy Even they have omitted using the propofol also. Adjunct TIVA drug, midazolam. Now I am not using midazolam, but it is used in the 0.05 milligram and total dose should be given less than 10 milligram. Midazolam infographics. Magnesium sulfate, one of the best agents which I am using in all my patients, whether it is from 2 years to any surgery for any sort of ASA patient. I am using in the dose less to high dose. So this is the magnesium sulfate. I called magnesium sulfate as the intravenous oxygen for the anesthesiologist. Believe the words intravenous oxygen. Once you give magnesium sulfate, then all the effect will start like antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizure, anti-shivering, anesthetic adjuvant, antacedent, mild sedative. Almost 32 clinical effects are there for MG-SO4 during anesthesia. I have listed here, but I am not going to read. This is just for your information. And this is a friend, philosopher, and guide for the anesthesiologist. Versatile drug. I request everyone to use magnesium sulfate, whether patient is any sort of surgery, any sort of age, sex, and any type of the system problem. Then dexamethasone. I do not have to say about dexamethasone. It's a common friend. It can be replaced by the even ondansetron. It can be given to all the patients. This is 3 drugs, that is dexamethasone, xylocard, and this lidocaine means lidocaine, and this magnesium sulfate is routine for me and every part of the world now. It is anti-inflammatory, prevents and treats postoperative nausea, vomiting, suppresses the inflammation. Patient have sense of well-being, good quality of recovery. Single prophylactic dose of dexamethasone 8 milligram can be given to irrespective of sex, disease, or ASA risk. And believe me, I am giving to diabetic patients which are not on the insulin. Insulin patients are there, then I am not giving. This is dexamethasone, and it has got all this effect. This is universal friend infographics. And third drug is pre-medication, is best companion for is lidocaine. Lidocaine I am giving intubation time, extubation time, and post-operative for 1 or 2 hours by the pint with the ketamine drip, that is ketamine and as an analgesic, post-operative analgesic, ketamine plus lidocaine combination in the pint. So this is also I am going to tell you that use these drugs frequently in your TCI-TIVA practice. It's a magic drug. See, what is the meaning of magic drug? See, magic drug is that your heart is irritated, your lung is irritated, your kidney is irritated. Once you give 1 milligram per kilogram lidocaine, then all system will be established. They will be functioning like in the rhythmic order. So at least 1 milligram per kilogram at the time of intubation, at the time of extubation, this give very good result for your patient's outcome. Some of the analgesic I am using pre-operatively, that is paracetamol, diclofenac, sodium. You know everything about these 2 agents, but the golden statement and thumb rule is that always give both the drugs before surgical incision to inhibit prostaglandin receptors. Once the surgical incision is there, and then if you give these drugs, then there is no effect or 50% effect. So these are the infographics for the paracetamol and diclofenac sodium. And one of the last drugs I'm using frequently in all my patients, whether it is for the ENT surgery, urology, or something like this laparoscopic, esmolol. I have replaced all the beta blocker with this esmolol because it is a central analgesia, can be given to more than 2 years of age. It's a opioid sparing effect. It gives the post-operative nausea, vomiting, and it is a very short acting and very much available in the market. So this is very rapid onset. Once you give, it will give the effect only for 2-3 hours. And believe me, this is my emergency friend. Whether my hypertension goes up, whether my tachycardia goes up, if I give these drugs, then everything is settled down with my normal values. Now, what are the TIVA combination? But what to understand before mixing any drugs in the anesthesia? All the anesthetists present here, they have learned in their MD or DA program that the concept of the anesthesia triangle works with the hypnosis, analgesia, relaxation, and their interaction. Any drugs entering in this prism triangle, they causes hypnosis, analgesia, relaxation, and they have to go with the pharmacodynamics, pharmacokinetics, pharmaceutical, and thermodynamics mechanism. So all drugs, they enter and they give the effect. So the rule is not mix more than 3 drugs at a time. And I have told you there is a very good article which drugs can be combined with which drugs with in Coleman Journal of Anesthesia just 7 years back. One of the article is here you can have all these things here, that all these things here, all the drugs, and here also same drug, and which go like propofol cannot be mixed with the C-citracurium. Ketomidate cannot be mixed with the vecuronium, like that. So this chart is very good. Okay, now the third thing I want to highlight that when you start your TIVA or TCI program, then how to start your drugs level. So we are the king or we are the queen, and our prince is propofol. Ketamine and dexmedetomidine are our supreme commander, first and second. Fentanyl and remifentanil are our commander, and other things they are soldiers like lidocaine, dexamethasone, diclofenac, esmolol, MgSO4, and midazolam, and other things. So here, when you start your TIVA practice in the patient, then you will decide which drug is to be given. So here, king will decide their military in the battle of TIVA whom to send alone or combination. Suppose there is a short GA, then you can combine with only give propofol. Prince is the only most common warrior and goes in every battle. King is not going. King is ruling the city or their kingdom, but his or her son, they will go in the TY kingdom and they will start the war. So here in TCI TIVA, Prince is the most common warrior. And in maintenance, Prince with 1 or 2 suprema. If the war is going long, if the GI is going more than 1 hour, then you can combine in the maintenance period your commander or supreme commander. Both the way. If you are having a TCI machine, then you can use fentanyl or remifentanil. Or if you are having no simple infusion pump or simple manual infusion, then you can use ketamine or dex. Now, what happens about the pediatric TIVA? In absence or presence of prince, 2 supreme commander go to the win small. It's a very small battle. It's a small battle to win the another state. So here what? Prince will not go. Prince will be silent. They will send the 2 supreme commander. They will go and battle. So here, remember in pediatric TIVA, dexmedetomidine and ketamine combinations are very much, they are going to fight. And whether it is a maintenance or whether it is an induction, Dexket is the prime popular choice of the anesthesiologist. And these are the combination. KPD means ketamine, propofol, dexmedetomidine, ketofol, ketodex, Dexket, fentanyl, propofol, remifentanil, propofol, MDF, PDF, MDF, ketomid. You know ketamine, ketofol, ketomid. I am not going in detail, but the rule is you just remember figure of 1. Whether ketofol, ketodex, ketomid. The rule is that the dose will go in the 1 milligram, 1 milligram or 0.1 milligram. This is my own invention since last 10 years, KPD TIVA, ketamine, propofol, dex, and there are so many articles came in the market now. Mixture is 1 gem, 1 gem, 1. And I was very happy with this combination in Corona time. And combination of all these drugs permits low dose of the use. The advantage is low dose of each agent and excellent analgesia and anesthesia. My all short GA, whether it is a URS or very short tonsillectomy or something like any short procedure like 10 minutes to 15 minutes to 30 minutes, then I'm using this combination. It decreases the dose of individual, stable hemodynamics, airway complication, and rapid recovery. See, each other drugs masking each other effects. Ketamine causes sialagoic effect and hypertension. Then dexmedetomidine causes anti-sialagoic effect and hypotension. Like that way. Propofol, fentanyl, we are not using now. RPTIVA, remifentanil, propofol. It is a very short. See, propofol can be given half the dose if you are using remifentanil. People now started only remifentanil all over the world. You can use by TCI pump only remifentanil, or you can use both the drugs in this TCI practice. So most widely used TIVA combination. I'll come another slide for this combination. Now, what are the methods of giving TIVA? Either with a single drug or with combination of drugs, single syringe technique or mixture of drugs or with only one drug, continuous IV infusion, syringe infusion pump, target control infusion, and lastly, automated drug delivery through. Like we are going for the cruise control driving of the car. It is like a closed loop system. The most commonly, since last 25 years, I am using this technique, single syringe TIVA with one drug or 2 drugs. No additional investment, simple syringe, only one syringe is used, either one drug or 2 drugs, short procedure, it can be practiced in NORA situation or in a low dependent setup. Then manual control infusion. Sometimes when surgery is going prolonged, then after induction, I put propofol in the pint and manual dosing with fixed infusion rate and with syringe or with IV drip. Now, when TCI was invented, before that, I was using this Bristol regimen for at least 7 to 8 years with my infusion, means maintenance part. So it is called as a 10-8-6 model. And here target was 3 microgram per ml in your blood level, effect side. Loading dose is 1 milligram per kilogram for induction. But when you give this loading dose, you have to give this either benzodiazepine or any narcotics before giving this bolus dose. Then how to maintain that? 10 milligram per kilogram per hour for 10 minutes, 8 milligram per kilogram hour for the next 10 minutes, and then 6 milligram per kilogram per hour thereafter for infinite time, whatever, 6 hours, 7 hours, even 24 hours. So this is the Bristol regimen. Now, before going that, people were asking, if you are giving manual infusion, then how to dilute the propofol? So first question, can we dilute propofol from its bulb or ampoule or for the IV infusion? Answer is yes, and it is written in the very well in the food and by FDA. It is compatible and can be diluted in 5% glucose to all the pints. Commercially available propofol is concentration of 1% means 10 milligram. So how to dilute it? Take 100 ml of 0.9 ml NaCl, remove 20 ml solution from the infusion, add 20 ml of 1 propofol in 80 ml NaCl. So infusion contains 2 milligram per ml, total 200 milligram. Maintenance dose is 6 milligram per kilogram, I have told you. So in 65 kg patient, it will be finished within 30 minutes. But rule is 1 part of the propofol and 4 parts of the dilution. It should not be less than that. And concentration should not be 2 milligram per ml, not more than that. So these are the references I have given. Now total intravenous sets are available. This type from BD or Baxter's or sometimes available in the another companies. Now target control infusion. Now these are the things which I have told you about TIVA and little bit about TCI. But what now we are concentrating more on the TCI. Target control infusion is an infusion controlled to achieve preset drug concentration in the plasma or the effect. Why TCI came in the market, target control? See, now before TCI invention, suppose in my practice, I was giving propofol for 3 hours, 6 bulbs. If you go 3 hours of TIVA practice, simple TIVA practice with the infusion, manual infusion, then I was giving 6 bulbs of the propofol, 20 ml. But in this TCI, if I put a 3 microgram per kilogram of target of effect side, then I have to use only 3 to 4 bulbs. So there is a saving of propofol and linear straight line of the brain fog level or depth of the anesthesia. How it is used? What are the key components? User interface to enter detail and target blood. It is the same as the simple infusion pump, syringe infusion pump, but the difference is here the computer is inside and software is there, which is because of the pharmacokinetic PK/PD model. We call it as a PK/PD model. And there is a communication control between pump and hardware. Here, when you start TCI machine, 4 things are required: height, weight, age, and sex. If you put that part, then this TCI machine will automatically calculate the dose of the bolus, dose of the maintenance, everything. So this is the way it is working. It's a 3 compartment all. Once you started drug from here, it goes in the central compartment. This is called a C1. It is also called as a V1. Then there is a C2 compartment, C3 compartment. From one drug, when you inject it from your IV line, it goes in the blood plasma, liver, then it goes in the highly perfused muscle tissue that is called a peripheral compartment. It also goes to the fat tissue, which is less perfused, very slowly, slow distribution. So slow equilibrium, fast equilibrium. So from C1 to C2, it is called a 1-2 distribution. So if you are hearing in your TCI lecture, what is K12, what is K21? If the blood is going from C1 to C2, then it is called K12. From T1, it is also going reverse way also. The redistribution is there. From muscle compartment, it will also go to the again to the central compartment. So K21, K13, K31. It is also going from central compartment directly into the brain, effect side. So it is called KE0. And then from central compartment, it goes in the metabolism. So K10, it is going out of the. So this is the normal mechanism of the TCI TIVA when you are giving drugs from the IV line. These are the TIVA sets are available. See, there are, you can give 2 drugs simultaneously. There is an anti-siphon valve. Intravenous infusion line is different. All can be mixed with this. And there is a microbiome Siamese tubing. There are 2 tubes you can see, and triple connectors are there. And there is a slide clamp also, where one drug's clamped or another drug's also clamped. These are the sets are available from some of the companies. How many models are available in the market? Just now in 2024, there are 3rd generation TCI pumps are available. First generation started in 1990, then in 2000, second generation came, and 3rd generation came in 2022. So it is called a general purpose model. So before that, how it was? It was specific drug model. Suppose if here is a propofol, like propofol, the propofol is having a Mars or Snyder model. This Mars model or Snyder model were used only for the propofol. And Minto model was only used for the remifentanil. Like that specific model is for the specific drug. Now what happens? This general purpose model is incorporating all the drugs in one. So you can use that simple TCI pump for all the drugs. So these are the TCI pumps are Arcomed, BD Elaris, HB Med Captain, and B Brown. Now 3rd generation pump, they are having Alivel model. This Alivel model, now I come to the which model is there for which drug. Now China has developed a single syringe, double syringe, and 3 syringe TCI. And he's the father of the modern TCI TIVA practice. He started in 1996 diffuser pump for the propofol. What are the benefits of the TCI? More predictable onset, more predictable offset, low incidence of PONV, short time of recovery, short time of discharge. Pump will say you in what time the patient will come out. Once you stop the anesthesia drug, either remifentanil or whatever the propofol, then the pump, it will show you the figure that patient will come out within the 1 minute 20 seconds or 2 minutes 30 seconds, like that. It saves the nursing time. It even saves the drugs, allow patients can early return of the drug. When patient control sedation by TCI, patient started TCI, patient itself started with the TCI sedation. So these are the pumps for the Marsh model and Snyder for the propofol. Then Padfuse, like pediatric pumps are also available, Padfuser, Kateria, remifentanil, Mintro. Then this is general purpose model. All the model like Alivel, Mildo, Bergman, even they have incorporated ketamine and dexmedetomidine, which was invented in just 2 years back. So all TIVA drug software in one TCI model. So just for the remembering you in your practice that these pumps are now available in India, and every year they are selling more than 1,000 bulbs, 1,000 TCI Arcomed or Alivel model in all over India. Now, those who are not using any infusion, then I have developed for my practice Tussar Choksi infusion. This is also called as a TCI infusion, as a maintenance. I was using 3 styles. Depends upon the tailor-made anesthesia with the time-space situation, whether patient is for the long maintenance, short maintenance, or which type of the surgery. So I was using propofol infusion 6 mg per kilogram in 100 ml non-venous, dexmedetomidine for the ENT surgery in 500 ml of RL, 0.7 to 1 microgram per kilogram, and KPD infusion. KPD infusion I was using for the major surgeries, that is head and neck, ketamine, propofol, dexmedetomidine, 0.5, 0.5, 0.5. This is in 500 ml RL. That is without TCI machine. People started closed loop anesthesia delivery system, and we are fortunate that in our India also, from Chandigarh PG, one of the doctor pioneer anesthetists has started this system very judiciously. Here, how it works, the inputs and outputs. Inputs are drug delivery, that is propofol and opioid. Input means drugs are going in the body. Then outputs are the vital signs, which will be shown in the monitors, that is evoke potential, bispectral index, blood pressure as a blood pressure or pulse rate. So how it works? Input is syringe infusion pumps. The drugs are invented in the body. Then output will be the monitors, means vital signs. And from vital signs, computer will decide how much drugs again to be injected. So it works like a vicious cycle. So it is called closed loop anesthesia. So these are the closed loop anesthesia machines are available, and there are so many benefits. Now TIVA can be used in the different sets of the patient: pediatric, ASA3, geriatric, obese. As far as our TIVA in neonates, just remember, for pediatric, when you start your this practice, then Dexcate you can start. I have started doing Dexcate even 1-year-old child. Suppose my patient is having a circumcision, then I give 1 milligram, 1 microgram body weight, then I give local block, and things are over. Even tonsillectomy, even foreign body removal, whatever the way. And TCI TIVA, I have told you about ketamine, TCI TIVA, Kataria and Pedfuser models are available. TIVA can be given to geriatric patient. Here the rule is go low, go slow, and always follow. And this is for every drug. You give very slow drug, means slowly you give slowly, very low drug, because their metabolism is 2-3 times slower than the usual ASA1 patient. Avoid hypotension, avoid dehydration, everything. Multi-para monitoring is first, but we can give safely TIVA and TCI in geriatric patient. Even in obese patient also we can give. But here my technique, and I will recommend that whenever you want to give TIVA practice or TCI practice, people are in European countries and in possibly in this UK, people are giving means putting igel without any suxamethonium. But my practice is I am always giving suxamethonium and then I am intubating. So always secure the airway in this patient, multi-para monitor and oxygen. The fundamental is that we can give very safely TIVA and TCI in obese patient also. TIVA can be given ASA3 patient, but be careful about their all the parameters. So surgical procedure done under TIVA, believe me, from OT to outside OT, from pediatric to geriatric, and from any surgical to medical special. Tell me one incidence of the skin procedures, like in skin clinic. I'm going for skin clinic, I'm going for radiology clinic where the trolleys are not available, where I'm giving TIVA. So that is the beauty of procedure. Means all the procedure, all the medical specialty can be covered by TCI or TIVA. So what are the checklist? All anesthesia, drug, airway equipment, oxygen, multi-para monitor are must. Ensures no leakage from cannula and patient IV cannula is always visible. Syringe should be labeled. This is a separate lecture for medication error, and I am very much confirm that this is the most mistakes done by the anesthesiologists across India by not labeling the drug. So always label your drug with name, date, and concentration. Infusion line should be checked every 15 minutes during surgery, especially when it was Corona time. The infusion set through which device delivered should have a lure lock connected. Nowadays, if you are going to your hospital, then discard the IV set which is not having a lure lock. See, my thing is, if you are using BIS, bispectral index, for the TCI TIVA or TIVA, then check the placement of the electrodes before and after surgical draping. And at the end, ensure all tubing IV cannula which had TIVA drugs by any method are flushed to prevent the inadvertent boluses in the ward, especially for the relaxant and dexmedetomidine. NHS came with a very good article about this, how to start the TIVA. So they came with the PRESS, PRESS, propofol, remifentanil, electricity, setup, settings, and start the TIVA. Now, what are the monitoring views? Still, after 35 years of my experience alone, I am the best monitor for my patient. I sometimes consider best as a pulse oximeter, best as a echocardiographic person, whatever way, because my hands is always on the pulse. And I can see that before pulse oximeter shows 90 or 80 SpO2, but I consider a patient is going less oxygenation. So be careful about, don't depend upon all the monitoring all time. You have to see your patients by head and body, means body and head, or their eye movement, or their another movements in the, like tachycardia or bradycardia, laryngoscopy. And another way of these machines we are using, multi-para monitor, bispectral index. It is not compulsory to use under TIVA, but if you are using TCI, then I will recommend that you should use bispectral, especially in neuromonitoring, neurosurgery is going on, or pediatric surgery. Evoke potential, process PG monitor, everything should be the monitoring line. So minimum requirement to start TIVA is dedicated TIVA or TCI pump, dedicated TIVA lines, non-return valves, and anesthesia depth monitor. So what is the message? TCI TIVA have become more popular, practical, and possible due to two main reasons. First, advanced knowledge of the pharmacokinetics, pharmacodynamics property of the drugs such as propofol, ketamine, dexmedetomidine, and other new drugs, making them suitable for the intravenous administration from any sets of the patients for any set of the surgery. And second, new concept came in the pharmacokinetic modeling that gives the syringe infusion pump, target control infusion, and closed loop system. So TCI TIVA becoming very popular. In 2030, you will see that TCI TIVA will rule over all the anesthesia techniques. And propofol with remifentanil seems to be the dominating TIVA technique all over the world. Now remifentanil will be taken care by the remimizolam. Some of the TIVA apps, if you are not having TCI pump, then you can use these apps. They will give the ready reckoner infusion calculator like that. TIVA, IV calculator, then infusion calculator, then anesthesia software. And in world, the only textbooks are available by Absalom, who is, I consider, is a grandfather of this TCI TIVA. That is Dr. Absalom. Second edition is on the way. Then this software,
Dr. Deepti,
copy is with me. So TIVA and TCI, in fact, patient-friendly, surgeon-friendly, anesthesiologist-friendly, economically friendly, environmentally friendly, and productivity-friendly. TCI TIVA will be a norm in the future practice. And future, like vaporizer, I dream that syringe infusion pump and TCI machine should be integrated in the anesthesia workstation. TIVA will be a norm and new normal. TCI will rule in anesthesia technique by 2030. And TCI TIVA with two models like TCI and closed loop anesthesia, both the model club with each other. They are available now. And if you want to play some of the game on the TCI pump, then also the TCI pumps are available from Asina. And this is the complex, my theater. This is actual photo of one of the theater. And this is the complex system, wires, gadgets, monitors, and machines. How we can work with this every day? I become like headache starts in my mind. So my dream is, this is the future anesthesia workstation of my dream. Only one cabinet where one button is there. If you want to give anesthesia, then put on this asleep mode. If you want to awake the patient, then put on the awake mode. And in between, if you want to take a coffee, then you can take the coffee from that. EI monitors, everything is available. So switch on and switch off anesthesia.
Can we
machine.
have some questions from the audiences?
Hello?
Yeah, Dr. Deepti, sir.
Just 1 minute.
Okay, sir. Yeah.
Ramimizolam, Sugamdex, TIVA. So my take-home message, step in your comfort zone with TCI TIVA for safe anesthesia, safe surgery, safe patients, safe environment, safe yourself. Some of the jokes, some of the TCI TIVA poems. So don't think, start TCI TIVA, and these are the steps where you reach your TCI TIVA practice. And we have started IOTA, and I request everyone to become a member. And these are the different societies in the world. So I love TIVA TCI because it is a precision, safety, future, and care. Thank you.
Thank you, sir. Thank you so much for such an extensive presentation. It really covers from A to Z of TIVA and the TCI. As it is rightly said by the George Kuras, the technology will never replace the teachers, but definitely in the hands of a great teacher, technology will bring a transformational change in our practices. So it's really true for the Dr. Tushar, sir. So any questions from the audiences regarding this? So just wanted to ask one or two questions. How you start your TIVA TCI? Like if you are starting with propofol and fentanyl or with an adjuvants, so which will be the first drug to be started, and how you go on with the other drugs?
My practice is very simple.
Okay.
TCI TIVA, I am restricted to some of the indicated patient, but I usually start with TIVA. I am not using nitrous oxide. I am not using any narcotics. I am not using midazolam. This is my
Okay.
principle. Once, suppose if I am taking laparoscopic hysterectomy, total laparoscopic hysterectomy with the ASI one patient, then my IV line is taken by patient's IV line is taken by the sisters in the ward. Then they will give the this ondansetron, antibiotic, everything. On the theater, they are coming by this coming to theater. I am giving DML mixture, that is dexamethasone, magnesium sulfate, and xylocard according to their weight level, very slowly over a period of 2-3 minutes. And by that time I will start oxygenation, and I induce with the patient. And before that also I given diclofenac sodium and paracetamol combination in paracetamol pint. So almost all the systems I'm covering with all the receptors. Then I start only with the propofol induction. Propofol I'm giving 2.5, at least 2.5 milligram. I'm giving higher side of the propofol, 2.5 milligram per kilogram. Meanwhile, I'm never putting supraglottic airway. I'm putting only tubes, and then switch over to just now on the Sugammadex and propivacin or vecuronium, or sometimes in the cisatracum. And maintenance will be with suppose if I'm using TCI, then suppose propofol will be the ideal for drug. Remifentanil is not available in my town, so till now I'm using propofol. But if the pump is not available, then I give the propofol infusion by the simple infusion method by 6 milligram per kilogram.
Okay,
Right.
and as a pump will ask you to put on the body weight of the patient. So which weight you consider, like ideal body weight, the lean body weight, or some terminologies like adjusted body weight is also there.
Yeah. For propofol, it is always considered to be the total body weight. So for propofol, it is always not ideal body weight. Ideal body weight and propofol, means total body weight. Ideal body weight is not considered in the propofol. For relaxant also, some of the drugs can be considered the ideal body weight, but in propofol, the machine also itself considered from the weight. That is the beauty of the software.
Do you prefer to give any anticholinergic drugs like if we have a remifentanil, dexmedetomidine, these drugs which are going on, the incidences of bradycardia will be there. So do you prefer to give any glycopyrrolate?
Usually for dexmedetomidine infusion, I am not preferring, because I am allowing bradycardia, I'm not telling bradycardia, but my patient, I am usually comfortable with the 45 to 50 heart rates. And as such, dexmedetomidine is a physiological drug, like that gives physiological sedation, where if you are sleeping and then if you count your own pulse, then it will be around 35, 40 to maximum 45. So dexmedetomidine is considering that way. It gives physiological and conscious sedation. And if you are doubting about your bradycardia and you are frightened, then you can give atropine or diluted adrenaline also. Sometimes, see, I have never heard that in dexmedetomidine because of the bradycardia acute. Rare cases is different. But in India, I have never heard that a patient died because of the bradycardia of the dexmedetomidine, acute bradycardia. If you are having a geriatric patient, if you are having patient on the beta blocker, you have to consider that part also, that where to give dexmedetomidine. So that is the tailor-made anesthesia.
Any questions from audiences?
First
Then
thing, this PowerPoint presentation I will give you. You can circulate everywhere. And any part of the Maharashtra or Sangli, anybody wants to have a workshop, then our team is ready. We will
Yes, definitely, sir.
we will come from our own way, and we will have a one day everything.
Just to conclude this talk today is about this TIVA TCI, I would say in-depth knowledge and the pharmacology of the drugs with equipment training, which will give the best out of TIVA TCI. So please keep practicing. Please start practicing. Thank you. Thank you so much.
Thank you, everyone. Thank you, and good luck.
Thank you, sir. On the behalf of IC MIRAJ-SANGLI branch, I also welcome Dr. Indrani Hemant Kumar ma'am, who is our national GC member. Welcome, ma'am. And now I request Manisha Patil ma'am to introduce our second moderator. Manisha Patil ma'am?
Yes, am I audible?
Yes.
Good evening, sir.
Ganesh, please present sir's slide. Yeah, it's already there.
Rupali.
Yeah, you are audible, ma'am.
Yes, can I introduce?
Yes.
Good evening, all. It's my pleasure to introduce Dr. Vaishali Mohod, madam. At present, madam is Associate Professor in Grant Medical College, Mumbai. Madam has special interest in cardiac anesthesia, echocardiography, and having more than 40 years of experience. Madam has She's principal investigator of phase 3 trial of levobupivacaine in India, 2007. Madam has 24 years of experience in undergraduate and postgraduate teaching. She has completed diploma in pain management. Then she was organizing committee member at ACTA National Conference 2020, Goa. Awarded at the hands of Honorable Governor of Maharashtra as COVID warrior for excellence work in during COVID-19. Madam is author of book published in June 2022, titled Operation Theatre Technique, Anesthesia and Emergency Care for Technician, Nurses and Paramedics. Thank you. Over to you, Madam.
Thank you, madam, for your introduction. Today's speaker is Dr. Balaji Asagaonkar. I think he doesn't need any introduction, but just to complete the formality, is the director of Ozone Anesthesia Group and is president of Snehaswali Care Center, which is a geriatric and pediatric care, palliative care center at Aurangabad. He has more than 15 research papers in national and international journals, and he has been awarded for a proficiency award by National ISA twice, Diligent Award by ISA National 2022, and Keshav Srushti Puraskar for social work, and courses in geriatry. He runs courses in geriatric medicine and palliative care, and appreciation award by Geriatric Society of India. Over to you, Dr. Balaji.
Thank you very much. I appreciate the efforts of MIRAJ-SANGLI branch to organize online webinar. Respected Dr. Vasudha Jadhav madam, President, Secretary Rupali madam, Vinayak Patil sir, GC member, and my dear friends. Now I will directly go to my topic. My today's topic is role of anesthesiologist in cath lab. I'm working in cath lab from last almost 20 years as a cardiac anesthetist. We look after cardiac cath lab as well as cardiac operation theater in Ozone Anesthesia Group. So whenever I ask myself, or whatever question you have asked me, what is the exact role of anesthesiologist in cath lab? Right now that IPL season is going on, and I like to compare the role like a wicket keeper. As a wicket keeper is always watchful for each ball, as an anesthesiologist also has to watchful continuously in the cath lab. There is no chance or no scope for complacent. He has to continuously motivate his team members to deliver better. And if anything goes wrong, needs immediate action, and he has to come into action immediately. Now, why this topic is important today? Because there is increase in the number of cath labs. When I started my practice in Aurangabad, there were only 2 cath labs, but right now we have more than 24 cath labs at Aurangabad. We are doing more and more interventional procedures. Right now we are doing more than 400 interventional procedures per month minimum at our city level. And the procedures are with a lot of variety. It is not like restricted to only a angioplasty or cardiac cath, but even a there is a neurological intervention, there is intervention device placement, even there is what we call as a TAVI, transcatheter aortic valve replacement, or like automatic implantable cardioverter defibrillator. All this complex procedure we are carrying out day in and day out in cath lab. And anesthesiologist is definitely required for all this procedure. At the same time, there is scarcity of cardiac anesthesiologist who can go for all these calls. So general anesthesiologist has to attend this call. So everyone who is working in a practice or who is practicing general anesthesia, who is practicing anesthesia has to one day or the other has to go to cath lab. So this topic is very, very important. Now, as an anesthesiologist, what are the challenges to us? Because many times anesthesiologists called for emergency problem in routine cases. There is suddenly hypotension, there is suddenly patient become irritable, and you called in cath lab to give some sedation. Or you may be called for angioplasty standby or for device placement standby, just minimal monitored anesthesia care, or you might be called to give sedation or at times general anesthesia. And invariably, the hemodynamics are unstable in that scenario. So it's very challenging for anesthesiologists to suddenly go there and try to control the situation. And even persons who are working there, they are not familiar with the theater. They are from medicine background, so they don't know anything about anesthesia. Once you give sedation, they think that it is like a general anesthesia. Oh, patient is not sedated, they will call you. So there is a difference between sedation, general anesthesia, that kind of information they don't have. Then even staff, when you are working in OT staff is very well familiar with general anesthesia, but in cath lab, staff is also unfamiliar with our technique or procedures. So in general, all this we have to handle in a very compromised and remote setup. So it is a very big challenge for anesthesiologist when he working in a cath lab. Anesthesia as such, is a very roller coaster journey of challenges, but we need to keep ourselves cool, updated and prepared so as to ensure safety of the patient. Why we are going there or why we are called there? Because we want to increase the safety of our patients. They should not suffer due to various complications in the cath lab. That is why we want to ensure safety. That is why we called. Now, how we should start as an anesthesiologist, how we should deal with this cath lab procedure. And I think we should start with the checklist. It is said that the checklist is one of the most high power productivity tool ever discovered. And what checklist that you must follow? Our anesthesia is invariably compared with the aviation industry. And whenever they want to take off, they always do the checklist. Means, is these things, is tire pressure is adequate, is petrol is adequate, is everything is checked. Similarly, whenever you are going in a cath lab, you should always see whether you are ready to control the airway. Is proper size endotracheal tube, ambu bag, oxygen, suction, is it available? Is emergency drugs are available? All antiarrhythmics, atropine, adrenaline, vasopressors, are they available? Is even if there is a defibrillator, whether it is charged, is it checked? These are the very small point, but they are very, very important. Even a patent IV access. Suddenly you went there is a severe bradycardia, you try to give and you come to know that there is IV is not inside. Intracath is not properly placed. So this checklist, if you follow, it is like under conditions of complexity, not only checklist help, but they are required for the success. So you must follow the checklist or make it a point that this kind of checklist is followed by the people who are running the cath lab. Another important aspect is PAC. Many times as anesthesiologists, we are called for cath lab almost for last moment. But still, even if you have got 5 minutes, 2 minutes, 3 minutes, you check what are the comorbidities of the patient. Is their patient is allergic to anything? Whether he has received morning dose of drugs. Suppose patient is to be taken for plasty, whether he has received antiplatelets or not. How are his vitals? Whether how is basic heart rate, how much is blood pressure. Just sneak on his lab, echo report, electrolytes, and whether he is NPO guidelines, because suddenly this patient might become irritable and he performer might ask you to give sedation, but if it's not NBM and if you give deep sedation, patient may vomit and aspirate. So these guidelines as an anesthesiologist we must follow. Somebody is continuously, there is disturbance. I request everyone to mute. Then as far as monitoring is concerned, of course, monitor is already attached there, rate, rhythm, STT changes, but which leads they are monitoring? Suppose they are doing RCA plasty and they are monitoring one end AVL, then the changes may not be seen, or reciprocal changes may be seen. So you should be careful which leads they are monitoring, whether many times SpO2 is not attached. You must ensure that it is attached properly. Arterial line invariably take, and intermittently we can see a trace on arterial line that you must observe carefully. Apart from that, coagulation monitoring, like activated clotting time, when you're in cath lab for prolonged procedure, we give a lot of heparin. Whether that heparin is working properly or is it adequate, that has to be monitored with the activated clotting time. As such, the temperature in cath lab is at very low even as compared to the OT, because it is for their safety of their instruments, safety of cath lab gantry. But disadvantage that patient becomes hypothermic very early, even 1 hour procedure, and invariably it starts with the shivering to the patient, and patients start disturbing the procedure, and it is very difficult to work when patient is not sedated and shivering. So you take adequate care to give warm saline using blankets and all these cares you can. You should always ensure there is extra length of cable, IV extensions and circuit, because they want to move the cath lab in various direction. And if this cable length, IV extension length is inadequate, you are not accessible to the patients. So you must ensure that these are extensions are there and you can access the patient from any angle. Now, what are the common complications that you observe in the cath lab? Like STT changes, they are very, very common. It's because of the inflation of balloon, because of stent, because of embolization, peripheral embolization of the plaque. STT changes are very, very common. And invariably they settle once you deploy the stent. But if they are not settling, you have to be see whether how the heparin has been given, is it adequately heparinized, whether you are maintaining the pressure. All these small things you have to do, but you have to do with it continuously with involvement into the patients. Like hypotension is also very common. Might be they are giving continuous boluses of NTG, and you need to treat this hypotension. Arrhythmias, all sort of arrhythmias, maybe simple bradyarrhythmias to ventricular tachycardia, ventricular fibrillation, all you will be able to witness this kind of arrhythmia. And you should be well versed in arrhythmia management. Of course, cardiologist will help you, but it's your duty also to try and give them suggestions, try and give to treat these arrhythmias actively. Then many times it is very common, I have seen so many times, operator unknowingly inject air into the coronaries and suddenly there occurs a stunning of myocardium. Once this occurs, means you need to treat it very aggressively. You need to increase the inotropes. At times, if there is arrest, you need to give the CPR. All these things happen in cath lab, and you have to be extremely watchful how these things are going on and what we can do for that. Blood loss, you are standing at a distance, but under the drip, there is a lot of blood loss occurring. One of the reasons for hypotension is this blood loss also. So you must keep a very close watch, and as our principle is eternal vigilance, that you must follow even in cath lab to avoid all these complications. Patients suddenly become anxious, irritable. These are very common complications you faced. Apart from that, there are so many rare complications, local anesthesia toxicity, tamponade. Recently, we have explored in last 3 months 2 tamponades which are occurred in a cath lab, or ventricular rupture, divide misplacement. These are the very serious complications. These patients need to be immediately wheeled into the operation theater, cardiac OT, and they require surgical correction for them. So these are the rare complications, but they are very dreaded complication. And if at all these complications occurs, anesthesiologist has to play a very major vital role in treating these complications. I have seen all these complications, and let me tell you good things that I have also personally seen surviving patient from all these complications. So if you act aggressively, if you act with knowledge, if you act as a team, definitely you can treat all these complications. Now, so many times we asked for sedation in cath lab. Just they want where patient is a bit anxious and you just give sedation. First and foremost thing is you must tell the patient, you counsel the patient that I am giving you, मी तुला फक्त झोपेचं इंजेक्शन देणार आहे, तुला थोडासा त्रास होईल पण खूप त्रास नाही होणार. This counseling is very, very important because if you give too much of sedation, patient starts snoring and it itself disrupt the operators, or it itself inhibits the operators to work. At the same time, if you give too less sedation, patient is not sedated, he is anxious, he is showing tachycardia, he is sweating, he is moving his extremity. This is also not acceptable. But you should go very slowly, just give some dose in titration, give it slowly, see the response. Every person's response for sedation is different, so you have to be extremely skillful while even giving a sedation. Then always give adequate local at puncture site, particularly for pediatric patient. I always try to give local myself to the pediatric femoral site because we give adequate local in an adequate area so that minimal anesthesia drugs will be required. This is where, and it has to be given, and you should wait for at least 3 minutes, 4 minutes, 5 minutes. Many times cardiologists suddenly give the local and immediately take the puncture. This is not good, means its local effect should be adequate before puncturing the femorals. Then, as I already mentioned, keep patient warm, give IV fluids, mobilize warmer into the cath lab, or at least cover the patient's head, cover the patient's upper body, which is invariably not covered under the drape. And this also helps to avoid the hypothermia or shivering. Sometimes under certain procedures like AICD or catheter aortic wall replacement or implantation, TAVI, where we need to electively give GA to the patients. And in that conditions, unfortunately, many times anesthesia workstations are not available. So we have to mobilize the patients on ICU ventilators. In that case, you might have to use TIVA. After today's lecture, I'm sure you will use TIVA very confidently. And TIVA is one of the very good technique, particularly in a cath lab when there is no very good quality anesthesia. Workstations are available, only ventilator is available. Now, for all hemodynamically unstable patient, it is better to intubate the patient and do the cases rather than doing hemodynamically unstable patient, doing cases on hemodynamically unstable patient. Better to first intubate the patient and do the cases. That will definitely help you in managing when patients, everything is under your control. For all prolonged cases, as invariably the arterial line is there, try to check ABGs. So many times you can correct electrolytes, you can correct acidosis, you can correct oxygenation of the patients. So it is very, very important to monitor ABG, and it is very easily possible during the cath lab procedures. Now, for all congenital heart disease cases, you must ensure that de-airing should be done properly. Otherwise, there are high chance of paradoxical embolism occurring through a patent foramina or patent IVS septum or anything. Now, as far as radiation safety is concerned, there is mandatory, all of you must take care of yourself. You must wear apron, thyroid shield, if eye protection is all available. And ideally dosimeter or cumulative exposure tracing should be weared. And as per recommendation, it should be 2 badges has to be wear, one above the lead, inside the lead apron, and other on the collar. Now, basically, this is a cath lab, and here is the X-ray tube. Radiation is going to generate from here. And as you stand away from it, the dose of radiation is going to decrease. It is said that the intensity of radiation proportional to the square root of distance away from the source. So, and invariably, as an anesthesiologist, we stand head end, which is very near to the X-ray tube. So that is why I mentioned about the adequate length of extension, and if possible, stand away from the patient. But you should stand at a point or at a place from where you should be able to watch the monitor. You should be able to watch the operator. You should be able to watch the puncture site and patient's respiration. Try to find out that place in a cath lab, and it should be at least 80 centimeter to 1 or 2 feet away from that patient, and it is relatively safe place where you should stand and provide the anesthesia care. Now, there are multiple other occupational hazards. Those who are working continuously in a cath lab, they are just wearing that very heavy lead gown. It itself causes neck and shoulder stiffness. Continuously standing causes varicose vein, low backache, muscle fatigue, edema feet, all. So being anesthesiologist, we have to take care of ourselves, do your regular yoga, stretching exercises, neck and shoulder exercises, wearing stocking, in between continuously walking. This all help you to save yourself from all the occupational hazards of cath lab. Now, clinical pulse, which over a period of time, over a period of years, what I realized that I wanted to share in last 2 slides. Experience is not what happens to a man, but it is what man does with what happens to him. So over a period of time, few things which I observed. Always, whenever you enter into the cath lab, always check anesthesia equipment, maybe laryngoscope, maybe ambo bag, maybe mask, airway. Airway may not be available, or somebody has placed airway somewhere else, and suddenly when it is required, it is not available. So always, whenever you enter, you check the anesthesia equipment, check the defibrillator. Always, certain drugs must be there, like atropine, glycopyrrolate, adrenaline, and invariably in all high-risk cases, or even in routine cases of angioplasty and all, we keep prepare this atropine syringe, adrenaline, diluted adrenaline syringe, phenylephrine syringe. These are very, very important. Even noradrenaline, antiarrhythmic like Kesol, magnesium, amiodarone. These drugs must be available, and you must ensure that they are available just inside the cath lab. Always check patient NPO status. As I already mentioned, personally check IV access. And if it is a high-risk case, unstable hemodynamics, you suspect it is a major case, always take extra large bore IV access. It is going to help you a lot in so many conditions, right? Maybe like starting inotropes, maybe giving fluid boluses, maybe giving blood transfusion. So always ensure extra IV bolus. Take some preemptive actions, whenever you are working in a cath lab. Suppose if you feel that he is giving NTG boluses, you just either increase the fluid if LV is normal. If LV is not normal, give small boluses of maybe mephenteramine, maybe phenylephrine, very, very small boluses. These are the preemptive action which will avoid further hypotension, and that you have to take. And once you start working with your full mind, you will realize when to take such action, but they are very, very important. Try to be perfect in advanced cardiac life support. You have to repeatedly revise the steps of advanced cardiac life support, and it will be required inside the cath lab. So it is very essential for all anesthesiologists to well verse with the steps of advanced cardiac life support. As I already mentioned, GA for all very high risk cases, they are very important. If it is a very high risk case, hemodynamically unstable patient, rather than planning to intubate the patient in emergency, it is always better to plan electively, intubate the patient, put him on ventilator, start TIVA, and hand over case to the cardiologist, and it will be done properly. So GA for all high risk case. Then preemptively, you can put CVP, keep inotropes ready in certain high risk cases. If there is a bradyarrest, many times there is sudden bradyarrest, there is no venous access, femoral venous access. Now cardiologist is struggling and the patient is convulsing due to hypoxia. What you can do is transcutaneous pacing option is invariably available in cath lab. You should be well versed with this. Just apply transcutaneous pads, and there is a separate cable that is required for this transcutaneous pacing. You just start this transcutaneous pacing, and once you can achieve the heart rate of 60-70, patient will get settled. You can have femoral access, and through which you can pace that patient. Be more aggressive on a witnessed arrest, because invariably if arrest is occurring in front of you, this arrest you can, I'm sure 100% sure that you can revive this arrest. So because you know the cause, you know the probable reason why it has been occurring. If you aggressively treat it, it will revive. So be aggressive whenever such kind of arrest occurs. For all high-risk cases, all cases, transesophageal, if you are well versed, if you are a cardiac anesthetist doing TE routinely, it's a very, very useful tool. Even if patient has landed in some complications, just put transesophageal echocardiography. It will give you a lot of information regarding hearts, and you can treat that patient accordingly. Never hesitate to take the help of cardiologist or cardiac surgeon, whosoever is available, our anesthesia colleagues, because patient is our priority, and take the help of all these people so that we can avoid or we can deal with all these complications. Always keep cardiac OT surgeon on standby. From yourself also, you must ensure this, because for device cases, for all TAVI cases and certain cases, only cardiac OT and surgeon is going to save that patients in emergency. So it is very, very important to you ensure that cardiac OT is free and surgeon is also. So good experience comes from, good decisions comes from experience, but unfortunately experience comes from making bad decisions. So it is not that you should learn from all your own mistake, but try to learn from others' mistakes, so you will be a more smarter anesthetist. At the end, anesthesiologist is now an integral part of interventional team, responsible not only for anesthesia and hemodynamic monitoring, hemodynamic maintenance, and ventilatory support of the patient. Now the anesthesiologist role has been extended to echocardiographic guidance of the procedure, and many times cardiac anesthesiologists are playing a vital role in this echocardiographic guidance of the procedure. So our role is increasing day by day, but we have to be updated, we have to be careful, and we must ensure patient safety whenever you are working in a cath lab. Thank you very much.
Thank you, Dr. Balaji. It was really nice presentation, sweet and short, but everything is covered. In your checklist, I would like to mention something for the residents.
Yes,
that is hanging lines, because the image intensifier is moving and our anesthesia machine is away, especially in cases of pediatric patients. Hanging lines, hanging circuits, hanging cable. So the resident should be careful about all those lines and so that there should not be pulling, stretching of the lines. And second thing, in cases of pediatric patient, we must take care of hypothermia by using warming blankets. We must take care of blood loss, because it is under the so it is difficult to monitor, and de-airing of all the lines in congenital heart disease cases, so that there should not be any air embolism. The precaution should be taken by all our residents, because I'm working with my residents, so I always tell them be careful about all these things. And secondly, I would like to ask you one thing, whether you are having a compact anesthesia workstation or using a normal workstation only.
No, madam, in cath lab, we don't have workstation. We have our age-old Boyle's machine with a bench circuit. But whenever there is a requirement of means workstation, or when we want to give GA, either we mobilize workstation from OT, because it is just beside cath lab, or otherwise, if in OT there is a procedure is going on, we mobilize a ventilator from ICU, and we do cases under TIVA. This is our routine protocol.
All the pediatric patients also, you are using ventilator and...
Previously, we used to give GA to pediatric patient, but nowadays I think our cardiologist has become well versed with all these procedures. We don't intubate the patient, basically. We just give without intubation, we do all these cases. And they are very fast nowadays. They are doing maybe ASD in 10-15 minutes, PDM maybe in 20 minutes. So we are not intubating these patients. But personally, I always sedate the patient. Once patient may be ketamine or some propofol, fentanyl, and I personally give local anesthesia That is what very important what I feel, because many times if you give very small local anesthesia or you give local anesthesia at one place and you take the prick at other place, that invariably it is very hurting for the patient. So, or as a cardiac anesthetist, many times they only told you take the puncture femoral or vein access, and we also took very actively involved in this.
Someone has asked about the LMA and TIVA. What is your take for pediatric patient as well as in adult cases?
If case is not going to be too much of hemodynamic changes and case is a bit straightforward, it is going to finish maybe in half an hour to 1 hour, I do put LMA. It's not like, but I ensure that patient is properly NBM, he has completed the NBM period and all that, those things. And I have invariably used this technique, and it's a very good technique. Means just put LMA and TIVA.
Balaji,
Okay,
have you
if we
used?
want,
Balaji,
if we
have
want
you
to
used
use,
okay, carry on.
no, sir, you can ask.
Balaji, you have used the dexmedetomidine and ketamine combination in your cath lab procedures?
For adult, I have used dexmedetomidine, ketamine, and propofol combination. But for pediatric, we have not used that much dexmedetomidine, to be very frank
I think
with you.
so many papers are coming from cath lab.
Yeah. For MRI, even for anesthesia, I have used dexmedetomidine for other cases, but not for cardiac cases. I have not used dexmedetomidine.
Secondly, I would like to ask you about the gastro LMA. Have you used it?
Yes, madam. I somehow not mentioned about it, but I have done 10 cases with gastro LMA, and it's a very beautiful asset for anesthesiologist. And through gastro LMA, we tried to put TE.
Yeah.
And it's a very beautiful
Do you
addition
feel that
to
it's
our.
more comfortable
Yes, absolutely. Absolutely
Balaji,
agree with you, madam.
Balaji, there is an editorial article from my friend Dr. Paul Zilberman from Israel in our Indian Journal of Anesthesia, just in June or July article. And he has written about the gastro LMA, and he has done the one slit at the angle, and where you can easily introduce your TE scope. So just go through that article, and it is a patented technology where he has given very good slit. Slit means there is a cut over the angle of that gel tube.
Okay. I will surely go through it.
I
But our routine gastro LMA also we put this tea, sir, and it's very easily
going.
Yeah, it's easily going.
Okay, fine.
Thank you from my side. If anybody has any question.
Gastro LMA is boon for the ERCP procedure.
Yes, absolutely.
The death means complication rate came down from 10% to even 3% from all over the part of the India with the gastro LMA when ERCP is going on. Otherwise, ERCP was the very much cursive for the anesthesiologists when the
one of the most challenging procedure.
Most challenging. Always
and that too in a prone position. If operator is used to do in prone position, then it's very difficult.
Very difficult.
Thank you so much, sir.
Yes, madam.
So, as we are going ahead with this ERCP procedure and all, any experience with the EBUS procedure, sir? Like use of TIVA in EBUS procedures?
EBUS means the drainage of you mean to say?
Endoscopy guided.
Okay. Yeah, I have done few cases, madam, but I have not done with gastro LMA to these cases. Because there will be sudden, suppose they want to puncture that that what you call as pancreatic cyst, and there will be suddenly gush of so much of material will come out. So in those cases, I think it is better to intubate those patients rather than using LMA cases.
And this question is to Dr. Tushar, sir. Is there any use of TIVA, TCI? You have done any cases for the endobronchial ultrasound biopsies?
No, madam. I mean, this specialty I'm not covering anytime.
Okay.
But somebody asked a question about the price of the gastro LMA. So usually I have heard it is available in 20 to 22,000 something. What is the cost of Balaji?
Gastro LMA? Yes, sir. I do agree. It's around 20,000.
Yeah. But it is reusable. People have used
Yeah,
it
yeah. We
1,000,
are
100 times,
using
100 times.
reusable,
Yeah,
definitely.
you can reuse it.
Yes, yes.
Dr. Tushar, sir, for pediatric patient, if the patient comes directly to the operation theater without an IV line, and we are planning to do it with TIVA case, and also how we initially will start, like
For that, you have asked very excellent question. There is a different set of the lecture. I have prepared a
Tushar
mocha
sir,
ice
please be loud. Your voice is not that much.
Can you hear me now?
yeah,
Yes, yes.
that's it better side.
I have prepared a mocha ice cube. Now, doka ice cube. Mocha ice cube is a midazolam, ondansetron, ketamine, and atropine combination, and I put in the as ice cubes. And that ice cubes I giving to all my trauma patients or emergency case patient or even routine cases 1 hour before actual the anesthesia is given, and that patient is monitored for 1 hour. And believe me, that ketamine causes a good sedation to separate the child from their parents, and easily we can take the vein. So that is now. I will tell you again the new method of the giving sevoflurane. Apart from this webinar, now American anesthesiologists have invented dragon method of the giving sevoflurane. It is called a dragon sevo anesthesia, where the child is in the cot, the big this big theater like this screen is there. Then child is seeing that dragon picture, and dragon exhales and inhales the some of the liquids from on the pictures, and child is told that okay, you also take from that mask to inhale and exhale, and within 1 minute the child has gone into the anesthesia. So this is the routine practice in American hospitals are going on. That is called dragon sevo anesthesia, which I have seen that part. That is just for the knowledge purpose. People are I'm telling anesthesiologists. So where this IV line is not available, then children can be treated like that also.
And like how we monitor the inhalation agent with that minimal alveolar concentration.
Yes,
So
madam.
we
Now
have-
Japan people have introduced a end-tidal propofol concentration, and the machine will be available within 5 years now from the today. Because see, Japanese people are very much aggressive in inventing the procedure specific instruments, and
Yeah,
you
it's
go
like a
through
more
the
of
literature.
objective means.
You go through the literature end-tidal propofol concentration. So it will be very much useful for us like inhalation agent.
So just a few words about the soft drugs, because I came across this word soft drugs. So what does it exactly means?
Soft drugs means like I sometimes it is today's paper. The in today's Times of India they came that okay, one of the death occurred in 2018 something from the very prominent actor. So it was because of the ketamine. Ketamine sometimes it is called as a soft drug because it is a rave party drug, and it was easily available. So soft drug it like drag. So some drugs off the label they can be taken as a I think I may be wrong sometimes, but in society culture they can take as a soft drug or means नशीली दवाएं जैसे like that. Any other person can highlight this.
Thank you from my side.
Okay, thank you, madam. So it was a very nice session.
Yes, it is
So
very
any
nice and
questions?
interactive session.
Yeah, very
Eh,
interactive.
Any questions from audience? Anyone want to ask?
But my suggestion is always you are welcome to call all of us from IOTA and our standing help to all part of the Maharashtra of all ISA to conduct workshop or even master classes or even webinar or physical presence. We 3-4 people will come and we will come with our
Yes,
TCI
yes, sir.
pumps.
Sir, in the month of the October, we have
Yeah. So
CME.
remember that part.
Yes.
Rupali,
Yes, sir.
how many points are for this meeting?
For this meeting, there is no, sir. Sir, for this
No
meeting, there
credit
is no
hour.
MMC points.
मग ते कुठल्या आल्या क्रेडिट आवर्स मग
ते पुढचा न्यूरो अनेस्थेशिया जर
1 जूनला सर जी ऑफलाईन आहे ना त्याला आहे.
I want to give you one good news that Maharashtra SAMs will get accredited very soon, maybe in next week. And henceforth, whatever the webinars you are going to do, they will have some points.
Can we conclude here?
Yes, madam.
Thank you so much. On the behalf
excellent
of IC,
lectures by both the speakers. Thank you very much, sir, for such a nice and elaborative lectures. Yes,
Thank you.
Rupali.
yes. On the behalf of IC MIRAJ-SANGLI branch, my sincere thanks to our today's faculties, Dr. Balaji Asegaonkar sir and Dr. Tushar Choksi sir, for such a elaborative and lucid presentation, also making the topic so simple by correlating with the, as Balaji sir correlate with these IPL matches, so it gets so much fitted into the mind. And Tushar sir correlate with that battle of the king between the kingdoms. So who is the king, who is the princess? So how the soldiers should go ahead. Thank you so much, sir, for and also both the speaker permit to as a faculty on first phone call and give their valuable time in their busy schedule. I'm also very thankful to our moderators, Dr. Vaishali ma'am and Dipti Haridas ma'am, for making such today's webinar fantastically interactive. And I'm also thankful to SAMS for providing this digital platform. And I'm also thankful to Jenica Technology and Ganesh for such uninterrupted audiovisual session. And thank you all the delegates and all my seniors, colleagues for attending this webinar. Thank you so much. Thank you all.
Thank you.
Thank you,
Thank
Edward.
you all.
Thank you.
Good night.
Thank you all. Thank you so much.